It is my great honor and pleasure to introduce Dr. Maisha Saida, who is a licensed clinical child and adolescent psychologist in Ontario. She holds appointments as a staff psychologist in the Division of Adolescent Medicine at the Transgender Youth Clinic here at the Hospital for Sick Children, and also in the intensive services for youth at Sick Kids Center for Community Mental Health. Dr. Saida is an adjunct professor at Western University, and she researches in the areas of health equity in hospital settings and integrating anti-oppressive and inclusive clinical practices into psychological interventions. Her session this afternoon is also in the area of examining the intersections among pain, gender identities and expressions, implications for gender-affirming pediatric pain programs. Please join me now in warmly welcoming Dr. Saida.
Good afternoon, everyone. As introduced, my name is Dr. Saida. I use she, her pronouns. And it's such a privilege and honor to be invited here and talk about something that I'm both personally and professionally compassionate about, given everything that's going on around the world and given what's today. It's a timely topic for healthcare providers to understand how we can provide gender-affirming care, particularly in the context of pain. So as we begin our next 45-minute session, I would like to propose some learning agreements for folks. So we are taking a well-informed decision to participate and listen to this talk. In the next 45 sessions and hopefully beyond, it is my agreement, and I'm proposing to all of you folks, that we recognize and respect gender diversities. If there is anyone who's not there yet, this may not be the right session. We also agree that transphobia, personal and systemic bias, and prejudice towards transgender and gender diverse people exist. Hoping, depending on where you are, whether you are a trainee, you're a learner, you're a clinician, or a researcher, at least there is an agreement with oneself to provide gender-affirming care. We may not know all the techniques or strategies or practices on how to do that, but I'm hoping that people are coming here with an agreement to do so. I also invite folks to come in with openness, curiosity, and flexibility for this learning. When we're open and curious, it doesn't necessarily mean that we accept all the perspectives that are being thrown at us, but for a moment, we're pausing, we're reflecting, and we're listening to perspectives, even if they contradict with what we have been taught or exposed to earlier. I also recognize that as we talk and as we discuss specific cases or anecdotes, it might bring back personal or professional memories of folks that you have worked with, or just your own personal memories. So also an agreement to taking care of yourself and the community that we're here with. This is a flexible adult learning environment. So anytime you need to take a break, you need to do something to take care of yourself, please do so. Before we begin, are there any immediate reluctance or objections to any of these agreements? Okay. Would anyone like to add an additional agreement? Okay. I'm going to take that as no and continue. All right. So then in this session, what are our objectives? We're going to begin with just enhancing our familiarity with what are the theoretical conceptualization to understand the intersectionality between chronic pain, gender identities, and gender dysphoria. We will explore some proposed etiological pathways and models. And then we would actually see that, okay, so these are what our theoretical conceptualizations and assumptions are, but what has actually been done in the research now, but also look at the research gaps, because that will have some implications for what is actually not known yet. And then at the end, we will wrap up with co-creating and taking away some recommendations for gender-affirming clinical and research practices for pediatric pain care. So let's begin with setting the context for our talk. And I want to begin with the term gender dysphoria that I will use quite a bit in this session. I would like to highlight that The use of the term gender dysphoria is not to pathologize gender identity or experience. As healthcare providers, we use this common language among other health providers to really emphasize and characterize the distress that individuals experience when there is a congruence between their expressed and experienced gender versus their primary and secondary sex characteristics and desired goals for gender transition. It's a language, it's a term, it's a diagnosis that we have to often use in order for youth and individuals to receive access and to approve eligibility for gender care. Furthermore, in terms of further contextualize our talk, according to Canadian census, the most recent one that came out in 2021, about 0.773% of Canadians ages between 15 to 19 identify as transgender and non-binary. We often have a common question that I get as the clinical psychologist at our gender clinic at Sick Kids is, do we receive referrals for youth who are identifying as non-binary or gender questioning or fluid or gender fluid? What do you think the answer is? Raise your hand if you think we do accept referrals for gender diverse or non-binary youth. Yes, the answer is yes, because non-binary or gender fluid youth can also experience dysphoria, and they might also have gender transition goals. So it doesn't have to be the binary always. We also know, and there has been a lot of research that has been done, that compared to cisgender youth, transgender and gender diverse youth are at an increased risk of several adverse mental health outcomes, including anxiety, depression, eating disorder, self-harm, substance use, as well as suicide intent, attempt, and unfortunately, sometimes also suicide completion. I also would like to give a broad definition of what is gender affirming care. According to World Health Organization, it is a social, psychological, behavioral, or medical interventions that is designed to support and affirm an individual's gender identity. So gender affirming care does not have to be only associated with medical transition. Even as a clinician, you're advocating and advocating for a young person to get access to a gender neutral bathroom in their school is a form of gender affirming care, because we would argue this is a form of a social / psychological intervention. So anyone where we are serving youth should be gender affirming, not just medical transition clinics, at least in theory. So I want to get a sense of who is in the room with us. So even at the moment, I can contextualize our discussions a bit more. So raise your hand if you are a trainee or a learner. All right. I mean, we are all lifelong learners. So yes. Raise your hand if you are a clinician. So even in the field of training, you're a clinician. Cool. Raise your hand if you're predominantly a researcher. Okay. Raise your hand if you work with youth. Okay. Raise your hand if you have provided a direct service to either a trans or gender diverse youth. Okay. Raise your hand after providing a direct service, you have reflected and you said, oh shoot, maybe I should have done something different. Great. Thank you for being vulnerable. And this is the part of lifelong learning, because this type of care is something that cannot be standardized, it cannot be manualized, and it is a person to person. And I reflect that when I went through grad school, this is something that I was not explicitly taught either. So just acknowledging that we are all here learning together and mistakes will happen, but we can also not just attribute that, oh, I have never been taught this and just continue to make mistakes, right? It's an opportunity for us to reflect on these mistakes and come together to really reflect and co-create and problem solve. How can we continue and enhance gender affirming care. So let's begin with the theory. So as the research has shown, one of the most common hypotheses or theoretical conceptualization, particularly as pain scientist or pain clinician, that you can have right off the bat is trans and gender diverse youth that are being referred to your pain clinics might report increased emotional distress and functional impairments compared to cisgendered peers. Not all, there's obviously, we have to take an intersectionality lens, but they're at a risk of experiencing more distress and functional impairments. Why? So we know that equity deserving populations or youth who are, or youth or individuals who are at increased risk of experiencing systemic adversities and marginalizations, they experience more life stressors than people who are not at risk of being marginalized. We know that trans and gender diversity identities are marginalized and minoritized, and it's not that they're at risk. A political and social climate has actually made a space where this discrimination and this minoritization, this marginalization have actually quite significantly heightened in the recent days. On Friday, we saw the province of Alberta tabling bills that pretty much banned pediatric gender care. So we know that as a minoritized and marginalized population, they are more likely to experience life stressors that's unique to their minoritized identities. We also know that just as a result of gender dysphoria, that distress that people experience because their identity and their expressions is not congruent with their sex, and it's not supported and affirmed in their environment. And this distress on its own could elicit mental health challenges. The common ones are depression and anxiety. Untreated dysphoria can lead to suicidal ideations and attempt. And many times young folks would often or might rely on substance use in order to cope with that gender dysphoria. So we also know, and you folks are the experts, I don't have to say that when folks are at increased risk of experiencing mental health challenges and substance use, a form of symptom presentations or expression could also be pain. And we also know that, especially when young folks are not affirmed and they have to work really hard to conceal their sex assigned at birth characteristics, and they're not being provided with appropriate resources, they might engage in dangerous or harmful. So a trans masked youth might, somehow get access to a binder, but the binder doesn't really fit properly and they cannot really go to their parent to buy them the right size binder, and it's getting really old. So that could, and because they don't really see or there's not access to other types of supports or resources, they're wearing that binder for a very long time. So that could also contribute to pain. Dangerous or unsafe tucking among trans feminine adolescents could also contribute to emergence of pain as well. So as we can see that it's not just the minority stress model that might contribute to pain, but both dysphoria and unaffirmed life that contributes to dangerous practices might also contribute to emergence of pain. But, yes, they're gender diverse or they're trans, but like other cisgender folks you all are providing care to, they might also have risk factors that are non-gendered, right? Surgical outcomes, an injury for which proper care was not provided. So what we're just seeing that it might be the case that they're exposed to more accumulative risk factors. Now, what are the significant life stressors that might be unique to our trans and gender diverse youth? Peer victimization is huge. And it's sometimes not just verbal teasing or bullying or mocking. There has been documented evidence of youth, transgender and diverse youth experiencing quite severe and serious violence in school settings or even out in the community, but also online as well. Unfortunately, sometimes we also might have caregivers who are not affirming and supporting of their identity. So there might be emotional, physical abuse or neglect once the youth discloses their identity or accidentally outed. Um, Transphobia, discrimination, micro, macroaggression by adults, by youth in their lives is something that TGD youth have to experience. But we're also living in an era where there has been an escalation of transphobic legislations. And this legislations often, I've heard personal stories where young people are often wondering and reflecting that in what time whether or not in 2025 this world would accept their existence. So it's not so. But when we think about the level of discrimination or the hate, it has quite profound impact on their well-being. And of course, folks might also have internalized transphobia, which is not surprising given the transphobic hate and discrimination that they're surrounded by. And as you can see, that all of these risk factors for significant stressors would have impact on each other. So what we have seen just in the community here in Toronto, that even what is happening in the US, what's happening in Alberta, the problematic studies that have come out from the UK, that is also impacting parental attitudes and beliefs and behaviors towards their child, right? So we're having more teachers and school administrators sometimes resisting or hesitant about some of the affirmed practices that are already in existence. So all of them have a cumulative effect on people's well-being. And given these life stressors and other risk factors that I have identified earlier, these are the areas of impairments that you could see in the young people that you're serving. So if my peer group or school is not affirmed, if I'm constantly being teased or rejected or just physically attacked, it would impact my school attendance, engagement, which would have an effect on my academic development. It could impact friendships, and we need friendships and peer groups to practice socialization to further advance our social functioning. As you know, that at least in Alberta, there's at least a proposed legislation that trans or gender diverse youth will not be allowed to participate in their gender affirmed sports. So that could also limit physical activation or other participation in vocational activities as well, especially if young people feel that they will not be safe or affirmed in the clubs or community activities that they will be going to. It could also impact accessing healthcare. We often hear quite non-affirming and very uncompassionate and just insensitive comments that has been directly relayed by healthcare providers to our trans youth and to our gender diverse youth. And many of the times they're just really reluctant and hesitant to even go for primary care. So many of the times those regular screenings and examinations that every adolescent need, people might just not feel comfortable to go and get that care. And one of the things that always resonate when I work with the young folks is it's like they're in this constant screening in every environment that they go to is, am I going to be believed of my identity? Are people going to scrutinize or constantly question who I am? So it's almost like there is this inner detective that lies within them, and they're constantly hypervigilant and making decisions. Who's safe? Who can I have continuous communication and relationship with? So this ongoing threats to emotional and psychological safety is one of the etiological factors for folks to develop anxiety and depression. So given all these, these theoretical conceptualization, it seems at least, evidence informed, it makes sense, but research on the intersection of chronic pain and gender identity is lacking. There's a lot of published literature on proposing that I think this is what's going on and this is what we need to do, but we don't really have a lot of data or evidence or even investigations to really understand this, and especially for children and youth. So what are the knowledge and research gaps? While, the proposed ecological pathways, I think, I don't think there will be many people who would debate about this, but it would be actually helpful if we have longitudinal studies to really understand what are the mechanisms that create implications on the relationship between the life stressors and the development, expression, and the maintenance of pain. So we're able to provide more catered interventions. While, again, there is hypothesis and assumptions that even the experience or expression of gender dysphoria could have a pain component. And when we are at the gender clinic, when we are assessing and supporting people with a gender dysphoria, we often ask the question whether that dysphoria is coming through physical pain. But that is something that even in the adult literature, we really don't have research to understand that. Now, from a more practical and pragmatic aspect, we don't have a lot of published literature to really answer the question is how many trans and gender diverse youth are accessing pediatric interdisciplinary pain treatment programs in Canada? We don't have a lot of numbers, published numbers to really answer that question, because theoretically it makes sense why they might have pain, but are they actually accessing the services? And I think it's an important question for you folks because it has implications and considerations for access to care, but also referrals. Another, a follow-up to that gap is if trans and gender diverse youth are being referred to interdisciplinary pain treatment programs, do their effectiveness, the treatment effectiveness and completion rates, are they similar to their cisgendered peers or are they different? Because that would have implications because I think we need those answers to make decisions whether our treatment demands, structure, and content needs to be modified if for some reason the treatment effectiveness or completion rates are significantly different between cisgendered and trans and gender diverse youth. So these are all the gaps, but what do we actually know from research so far? Most of our research has been done with transgender and gender diverse adults, mostly pain expressions or pain development following after the start medical transition. But because we are in the context of pediatric pain care, I will focus mostly on pain and hormone replacement therapy, because in Ontario, youth have to be at least 16 or older to be approved for surgical intervention. But given the wait list, youth are essentially not accessing surgical interventions until age 18, unless the family have the means to do so privately. And in the last, I would say, 2 years or so, there are a few studies that have come out to give us some understanding of are trans and gender diverse youth accessing pediatric pain program? And if so, what do we know about effectiveness and completion rate? So there are some emerging research on the effects of hormone replacement therapy, or HRT, and pain diagnosis, reduction, or magnification in TGD adults. So for example, there are some, again, emerging research with a smaller sample size. We cannot say that for definite, but there are emergence of orofacial pain after starting estrogen therapy or worsening of pelvic pain following testosterone therapy, which is sometimes which is inconsistent, because there's also adult literature that transgender might have a protective effect on cisgender men when they are on testosterone. So even though we are seeing this emergence or correlation of pain when adults are starting their HRT treatment, you folks know, you're the experts in the room, that it's really hard to say that it's the hormone or the HRT therapy that is only or solely contributing to the expression or emergence of these pain. Pain expression, how we experience and embody our pain, is so solidly impacted by our own individualized stories and interpretations and understanding of our own experience. But we also know that pre-existing mental health challenges and previous or ongoing exposures to complex and traumas could also impact pain magnification or other types of pain challenges. But what is something for you folks, just to have an FYI, is that you folks may receive referrals for youth who might have different types or a worsening of a existing pain. And so far, the research with the youth is only among transmasculine adolescents who are on testosterone therapy about just complaining of worsening of pelvic pain. So that's just something, an FYI, in terms of the referral profile that you folks might see. However, I was reflecting from our patient caseload, and I could not think of any transmasc youth complaining of debilitating pelvic pain. But again, it's based on so many other intersectional factors that we talked about. So the next one that might be more pertaining or contextualized is, what are the challenges and experiences of trans and gender diverse youth who are attending pediatric interdisciplinary pain treatment programs? So Suraj and colleagues, it was a really exciting and study to be published, because we don't see this a lot. They completed retrospective chart reviews of 491 young patients who were admitted to an intensive interdisciplinary pain treatment program over a 4-year period in Midwestern USA. So just like some of the theoretical conceptualization that we have from the, about 491 youth, about 6.11% of the youth identified themselves as either trans or gender diverse. And they did present as more emotionally distressed and functionally impaired compared to their same age-matched cisgendered peers. However, this is the good news, is when accounting for baseline scores, the TGD participants who completed the full treatment reported similar scores to cisgender peers at discharge, which means the effectiveness was similar between both cisgendered as well as TGD youth. Yay. However, this is something that might not be surprising, but this is something that we have to be, this is I think one of the most important takeaway from this study is, compared to their cisgendered youth, TGD, trans and gender diverse youth were significantly less likely to complete treatment. So before we move on to what might be going on, any ideas from your own expertise and practice and experience, and if some of you folks are part of a similar interdisciplinary pediatric pain program, first of all, does this surprise you? No. Okay. So what might be some reasons why the completion rate is lower for our transgender and gender diverse youth? Yes.
Lack of acceptance or perceived lack of acceptance of themselves, particularly, but maybe other people.
Right. So at least they're perceiving that my care providers are not affirming. Yes.
But this is an inpatient intensive pain program. I do wonder about safety, if they feel safe in that space as well.
Absolutely. Yep. Yes.
The other social context, like family, peers relationship, other external context that these participants, that patients suffer out of the program.
For sure, yes. Because I would say, like, they might, in addition to pain, they might have other mental health or substance use or other effects, or other challenges that going on where they just could not participate optimally, because sometimes our intensive programs can be quite demanding. So because there were so many things going on that it was just not possible. Yes.
I was gonna say, I worked with friends,
Yeah.
in the past, and I know for, it was around 14, 15 at the time.
Mhm. Mhm.
For him, the one of the things that was really exciting is when he was trying to access pain clinics, they kept getting declined. Him and his family, he's a very accepting family, very supportive, but they kept getting declined, and the reason was stated that they wanted him to do like CBT therapy, dialectical behavioral therapy first, before he came into the program. And for him, like you said, being so hypervigilant from who's safe, words like behavioral therapy are very triggering for him.
Yeah.
It's like, are you telling me that there's something wrong with me? How I'm behaving is wrong.
Yeah.
So it's almost like another barrier. You have to fix your picture psychology.
Yes. Yeah.
And that was very, very disappointing. Sort of families that have that, and to this day, they're still having.
Yeah. Yeah. May I have your name if you're okay sharing? Jody. Jody, I love it because you just foreshadowed my entire presentation. Because we're going to talk about these barriers about like specialist care versus interdisciplinary holistic care. And that's actually a very common reason why youth do get declined, because the common question is, you need to fix your mental health first. But this youth will not get up from their bed to fix their mental health. So I don't know what to do. Anyways, we'll get into it. Yeah. Any other barriers to care? Yes.
Yeah, I think these programs have evolved to become tailored to the values and preferences of cisgendered kind of normative values.
Yeah.
Because this is a relatively new space.
Sure.
And so I think there are some barriers pertaining to that as well.
Absolutely. Yeah. Yeah. All right. So as we advance to the last 10 minutes of our time, what are some recommendations, or let's co-create some agreements. So for the clinical care, let's start with the basics, and folks are probably using them. Using affirming pronouns and names, not just when you're verbally communicating, but also in written communication in charts. I often see where just the first sentence says that Joey is a assigned female at birth, is a trans masculine youth, and the rest of the charts goes back to dead name. Unless the youth have specifically have requested that they have not come out to their caregivers and they don't want their affirmed name in charts, there has to be a clinical rationale if you're not using their affirmed names or pronouns in the chart. We also provide consultations across the disciplines here in the hospital about using gender inclusive language. So not using menstruation or periods or breast development, but using more gender inclusive language like monthly bleeds, chest tissues. If we're talking about romantic or sexual partners, sperm producing partner versus egg producing partner. And this is something that one of the things that we always have to reflect and assess is if you're working with a young person who has not come out to their parents or even to schools or other adults or care providers, do not accidentally out them. Beyond use of pronouns and gender inclusive language, as an organization, as a clinic, if you are seeing there has been an increase of referrals for trans and gender diverse youth, there are organizations such as Rainbow Health Ontario provide courses and didactic workshops for healthcare providers as well, where you are learning more beyond just the basics of pronouns, more about gender affirming care, gender development, and other needs of trans and gender diverse youth. Now, many of the times, I think as care providers, we see the concerns and the challenges, and sometimes those concerns or challenges are quite escalated. And I know as a healthcare provider internally, I am worried that I mean, I'm not a pain specialist, but if I hear a young person saying that I sleep with my binder on, I was like, that is not good. That's not okay. But I also understand the distress, the dysphoria that these young people are experiencing. So when we want to get in the table of collaborative problem solving, I think the language is really important with young people. And as a psychologist, I often take approaches from emotional focused therapy and compassion focused therapy to really relay, my own concern, but also invite that person, that young person, for collaborative problem solving. So in this case, let's go back to Joey. Joey, like, I get it. This distress and dysphoria is so immense and so significant for you. This pain is intolerable. And I get it that maybe wearing the binder is the only way that you are falling asleep at night. But as a healthcare provider, I'm also concerned about breathing. I'm concerned about potential back pain and other things that might be happening because of this. So can we come to a table where we can take a middle path, where we can take care of your organs, we can take care of other holistic parts of you, but also maybe we can provide other strategies to support with that dysphoria. This type of language, this type of awareness and recognition that you're just not thinking that Joy, the 16-year-old, is just being an irresponsible, callous adolescent. You understand their distress, you understand their pain, versus just saying, Joey, you're wearing a binder for more than 8 hours. That's not safe, that's dangerous. The solution will be to just remove it. Now, and I think this is where what Jody was saying, that, for us to, again, whether this would also include really listening to the voices and perspectives of existing transgender and diverse youth who are already affiliated with your program, to identify what could be the unique barriers to treatment, completion, or participation for folks. We often see that youth just have reduced not youth, some youth, particularly if they're living in a rural setting in Ontario, if their neighborhood or community is not really affirming, there is higher rates of transphobia or homophobia. But if that youth is also racialized, so there's this cumulative effects of risk. And they just don't feel safe. And it's actually not just perception. Sometimes it's actually not safe for them to leave the house. So they don't get a lot of physical activation in. So how are we going to modify that rehabilitation needs that is commonly associated with pain treatment to provide support for this young person? And many of the times you might have young people who have a lot of concurrent both mental health and physical health needs. And I often say to young people, this is the language I use, that we all have goals. And those goals could be honorable, those goals are supported, and those goals, of course, make sense. But when we have internal storm and stressors, it impacts the way that we think about our goals. It impacts our own self-efficacy of reaching the goals, and just do everything that we need to in order to participate in the goal. So many of the times, even in our own gender clinic, we take a holistic approach where mental health needs have to be supported as they get ready for more medical-based intervention. And that's something, the language that we use, that nobody is questioning or debating about your gender identity or transition goals. But these internal chaos, you call it anxiety or depression, this external storm, we just need to take care of it so that your self-efficacy is optimized in order to reach the goal. Because if those chaos and stressors are not being managed, you will lose the energy and you will be exhausted to reach your goal. And similar to, I want to bring back just a case study. We have a 17-year-old youth who began their life with quite significant parental abuse. And there was numerous child protection services involvement. They also have very significant, serious dysphoria about their monthly bleeds, so when they were younger, that has led to the development of quite serious eating disorder. This might not be new to folks, but we often see eating disorder among our trans and gender diverse youth because they think that by not eating, they can suppress or change their puberty trajectory. And for this young person, to some extent, it was affected. They were not getting their monthly bleeds because they severely restricted their eating. They also have, and this is like genetically, like even their parent experiences quite severe pain. They also have very severe leg pain. So we have the 17, and again, live outside of Toronto in a region where there is limitations of all different type of care. They're not living with parents, living with a friend. So if you think about intersectionality, everything is so hard. This youth, among all other, trauma-induced emotional distress, one of the things that they really enjoyed was art and knitting. And their narrative right now is that I'm in so much pain, I cannot move, I will not go to school because I'm in pain, I will not do art because I'm in pain, I will not get up from bed, I'm in pain. I'm in pain, I'm in pain, I'm in pain. They're also not eating, have quite severe emotional dysregulation, which creates barrier even in their gender care and getting ready for HRT as well. But because they're also not eating, they were not accepted for pain care. And it makes sense, right? Because pain care does involve a lot of physical and behavioral physical activation. And the recommendation makes sense that we really need to figure out your eating first before we can do pain care. So I think at this point, I don't know there is a right answer yet. And we see this complexity, unfortunately, more often than not. So in these cases, what is it that we do as a group? When a young person has so many concurrent mental health and physical needs, and as if you folks have said, like when certain inclusion criteria, exclusion criteria, and other things were designed into the development of these programs, we were not really aware of these unique complexities. So I know that even in a hospital such as ours, it's a privilege to see so many different specialist expertise. But maybe it's time for all of our expertise to actually come together to a table and really work more as a larger interdisciplinary team, right? The eating team, the mental health team, the gender team, and the pain team to come together to really be like, what do we do for this young person? And lastly, just a quick 2 minutes, I'm running out of time. For researchers, literally, metaphorically, don't other TGD youth, demographic sections. It's not male, female, and other. Transgender binary youth, their understanding and interpretations of their dysphoria, their gender, their pain are significantly different from somebody who's trans masc versus trans feminine versus fluid. So please provide an open choice and actually understand their experiences individually. Many of the screeners and behavioral measures that I use in psychology, and probably the same for other measures, are often very gender exclusive and gender oppressive. So please review and assess them, and if possible, make changes if possible. I know our TGD youth are often comprised of smaller sample sizes that sometimes create resistance in doing those fancy statistical analysis. So at this point, our recommendation is to also integrate qualitative methods to really examine their stories and better understand their experiences. Thank you all for listening.
Wow, thank you so much, Dr. Saida. You've given me so much to think about, and I can't believe how much you were able to present in the short time that you had. My mind is just reeling, and I have a million questions I would like to ask, but I think I will hold myself back and allow and open it up to the floor to ask questions. And if it's all right with everyone, I know that the next session is supposed to be starting, but I'd like to absolutely honor that talk with at least 5 or 10 minutes of Q&A and run into the rapid fire, if that's okay. Yeah, okay, perfect. Okay, I'll open it up. Yeah, and please introduce yourself again, even if you've asked a question this morning, because we may have slightly different people in the audience morning to afternoon.
I'm wondering how many children have gender dysphoria, and following some of those in adulthood, how many then will try a path of wanting to actually become a trans person, and how many have lived with gender dysphoria but don't actually make steps of gender affirming surgery or gender affirming changes.
Unfortunately, we don't have examples for those, but I think the question is how many young or how many adults would just not access or would not have done surgical interventions despite their gender dysphoria. So I think that, we can do like a population based ask people. But unless we're actually asking them the reason why, I think it's really escaping for us. Social interventions, there's a lot of barriers to receiving surgical interventions. So I think I would be more interested in reasons why. Was it because I would, in one hypothesis, is the story without getting into surgical interventions, versus other behaviors. It's published literature. Reasons why adults. We also made adults for functioning or who have been coming under their adulthood. So that might also trigger care. Yes.
I wonder if you have any suggestions when dealing with our colleagues and peers who maybe have some degree of discomfort with TGD, and when we're invited into and we see the preferred pronouns and the chart, but then there's sex assigned at birth and a legal name on chart, and you can see that some people are very uncomfortable with this and they're concerned they might go in the room, use the wrong pronoun, use the incorrect name. And I'm just curious if you have suggestions when working with colleagues who display some degree of distress, how to support them to be a better healthcare provider for patients.
Yeah, that's the answer. So I think that some of this messaging, what I call clinical agreements, demonstration. So that's also something I start on top of.
Thank you so much once again. And please, everyone, join me in once again thanking Dr. Saida for a phenomenal presentation.